So I know it is afternoon again. Thank you everyone for joining. So my name is Tracy Summer. I'm going to be helping to facilitate today's webinar. And again, as I mentioned, today's webinar is hosted by Max for Moms. Max for Moms supports providers treating patients who are pregnant or in the postpartum period, questions about any substance use disorder or questions about pain management. It's an extension to our MAX program. I'm the Maryland Addiction Consultation Service. Again, I'm supporting providers across the state. Our program offers phone consultation for clinical questions. Our one line is open Monday through Friday from 9 to 5. So you can call us anytime and get like a curbside consultation. We also help with finding resource and those information and also education and training opportunities, just like today's webinar. Again, if you have any questions, you can always contact us at Max for Moms. And thank you, Marciel, for putting information into the chat as well. Before we dive in, and as our presenter will be joining soon, again, thank you for your patience. I'm going to go over some housekeeping items for today. You can use the chat during today's training for any questions that you might have, and there will be time at the end for questions. A copy of today's slides and the recording of today's training will be available on our website within 1 week. I also want to mention that our program Max, we are currently surveying prescribers across the state to kind of better understand the landscape of buprenorphine access in Maryland. So our survey closes soon, actually in just a couple days, and Marciel is going to put that information into the chat. But if you are a prescriber on today, if you wouldn't mind just kind of taking a moment, we really encourage you and your expertise to complete our brief survey, and you can also share it as well with your network. Also going to go over the credit process for today's training. Immediately after today's training, you will be able to log back into your portal through Oasis that you signed up for today's event, and you'll be able to access that link in order to do your eval. In order to get credit, you must be online for the full duration of today's training, and you must complete that eval survey in 7 days from today. Again, you can log into your portal in Oasis in order to get that survey and also to access any CE certificate, whether you're looking for CME or CEU certificates. And let me see if go on to the next piece. I see, Dr. Welsh, that you're on. Big thanks to Zach, our IT, for helping, and apologies for any difficulties, but I'm glad you're on. And if you want to go ahead and start to share your slides, you should be able to. I did kind of an intro and housekeeping items, and then Dr. Welsh, I'm happy to present you, and then I will kind of hand it over to you. So as I mentioned, our training today, Max, is hosted by Max for Moms, and Dr. Welsh is one of our consultants and the PI for Max for Moms. He is an associate professor in the Department of Psychiatry at the University of Maryland School of Medicine. His main area of clinical work is in the area of substance use disorders. He's worked in various in- and outpatient settings as well as telemedicine, using methadone and buprenorphine maintenance. And an area of interest is in pregnancy and the medical complications of addiction. He is also the medical director of the Substance Abuse Consultation Service at UMMC. He works with the Baltimore City Health Department as well as the State Health Department on expansion of treatment for opioid use disorders, as well as for needle exchange and opioid overdose prevention. He also works in Kenya to increase treatment of heroin use disorder, and is involved in trainings for various healthcare professionals. And he's also the medical director for the State Center of Excellence on Problem Gambling. So Dr. Welsh, thank you again so much for being here and for presenting. I'm now going to turn it over to you.
Okay, can you guys hear me okay?
Yes.
Does the PowerPoint look normal?
Yep.
All right. Okay, yeah, I don't know what happened. It was making me register and then it wouldn't let me register because I'm a host. So it was a vicious circle.
Well, thank you so
Um,
much for your patience.
uh, all right, yeah, well, so since we're starting late, I'll probably just skip through some things, but yeah, so I'm just going to give an overview of addiction treatment and talk, specifically about issues with pregnancy, but really because I think there are a lot of non addiction providers on. So just really even just talking about the basics of addiction treatment, which I think a lot of people aren't really familiar with. So no disclosures, we'll skip that. Just real briefly, I want to talk about terms because it's as we're talking about treating people with substance use disorders, when you hear things in the news or read studies or whatever, it's really important to know what is being discussed because there are all these, we won't go through all the terms, but all these terms kind of get used and interchanged, and sometimes they're talking just about use and not about a use disorder. And, obviously the consequences, misuse can be very different. So it's really important to be aware. It's also just, we're going to talk specifically about opioid treatment. These are just some terms there that are kind of specific that we'll skip over. And another term that really we try to avoid is talking about the baby being addicted. We'll talk about kind of physical dependence, and the baby may have physical dependence, but it isn't addicted. So we'll also, when we talk about opioid use disorder, it's really important that there are different ways that people are using, and just hear some of the examples. But somebody can be prescribed an opioid for chronic pain and taking it appropriately, could be prescribed medications and not taking them appropriately, could be using illicit opioids, could be taking their opiate treatment medication appropriately, and some people are not taking them appropriately. So it's important that there are a lot of different ways, and again, we'll talk more about some of those. Just a little bit about kind of the potential impacts as we talk about consequences of substance use disorders. And there are some that are related to the substance themselves. We won't really focus on those today. But things that can affect mom, can affect fetal development, and can have long-term outcomes. But a lot of it just has to do with the substance use. Not taking care of yourself while you're pregnant because you're out using. Um, Obviously potential legal consequences, risks in that you're taking in order to get substances. Obviously, if you're injecting, the risks from that, and otherwise, a lot of risk for abuse when you're using. So again, there are a lot of different potential consequences that will that you're talking about when you're talking about substance use disorder, and you kind of have to be trying to address all of them when you're talking about treatment. I'm just going to skip over the epidemiology. Again, because we're really going to focus more on treatment. And we don't have great epidemiology for pregnancy. This is just looking at women, but it's really hard to study, large scale epidemiology in pregnancy because a lot of people don't don't want to talk about it and try to hide it. So, all right. For people who aren't familiar or just need a kind of reminder of the diagnostic criteria for substance use disorder that we use in the US. We use DSM-5, and there are 11 criteria, and you need to have a minimum of 2. And what's important is the last 2, that's tolerance and withdrawal. So those are kind of the 2 components of physical dependence. So like I mentioned before about saying that a newborn has a addiction or a substance use disorder, just doesn't make sense. They can have physical dependence. So they might have withdrawal and they may have tolerance, but that in and of itself is not a a DSM substance use disorder. It is a clinical condition and you want to be aware of it and address it, but you really have to have other consequences, effects on your life, lack of ability to cut down or stop using despite, you know, current problems. So again, it's not just being physically dependent. If you're not aware of the qualifiers, so you again, the current previous DSMs were different. They had different diagnoses, but now there's just the one diagnosis, and then it's mild, moderate, or severe, depending on how many of those 11 criteria that you have. And then the core specifiers, so you can be in remission. Again, previous DSMs did this differently, but now remission is really, so the first 3 months you don't get any credit. After 3 months to 12 months, you can be in early remission, and then after 12 months in sustained remission. And then we also kind of uniquely in substance use disorders put in there like on maintenance therapy. It's actually really just adds to you know, the already kind of stigma against our treatments. You know, specifying it in the diagnosis. We don't do that for anything else. You don't say, you know, diabetes on insulin in the actual diagnosis. So again, it kind of contributes. What's real important though is even when we're talking about being in remission, it doesn't necessarily say anything about actual use. It has to do with meeting those criteria on the previous slide. So it means that you're focused on the consequences, not on use. And so somebody can be in remission even if they're still occasionally using, as long as they're not meeting, you know, any of these consequence criteria. Also, as we're talking about treatment, we, you know, have to talk about recovery. This is the SAMHSA definition of recovery. And you see, again, it's very kind of broad, focused on, you know, living a healthy life, doesn't get into whether the person, you know, doesn't talk about use. So again, it's really trying to focus more on, you know, how someone's doing, you know, these 4 dimensions here, their health, home, purpose, and community, and less focused on their use, doesn't mention total abstinence, and importantly, doesn't mention being on medications. We'll talk a little bit more about that, but a lot of people think if you're taking a medication like methadone, then you are not in recovery. Yeah, as we're talking about terms, just another one as we relapse, because that's very important. We see it a lot with people with substance use disorders. There's been, yeah, as we're trying to kind of try and help with stigmatizing language, we're trying to get away from other terms like slip flaps and just talk about the actual behavior. So resumption of substance use, recurrence of your substance use disorder. So really focus it on, you know, much more on the behavior and not focused on the person as we often do. So as we talk about treatment, you know, I think this is obvious, but again, if you don't work in the field of addiction, I think it's easy to think that most people with addiction don't do well. It's what seems to, you know, be in the news, and it's easy to see that, but you know, a lot of people really do well. The basic assumption is that people can change, and that most people, when they change, their tendency is to change for the positive. Obviously, there are examples of that not being the case, but most people, you know, can change and change in positive ways. Important as we're talking about this to recognize that ambivalence is really a key component of change of behavior. That once you've been doing a behavior for a while, no matter how destructive it is now, usually when it starts, there was some positive to it that kept you doing it. So there's always some ambivalence there, and that as providers, that's a lot of what we're trying to do is help people, you know, figure out how to get beyond that. you hear this a lot in pregnancy, and we'll talk about this, but things in someone's life really can influence kind of how far they are along, that kind of continuum of wanting to make a change. And becoming pregnant can be a big one. So again, as we're talking about this population, in a lot of ways, people can potentially do better because they have a really strong motivator that a lot of times other people don't have. Again, this is talking about in general, not just in pregnancy, but studies that look at addiction as a chronic disorder show that outcomes are actually very similar to other chronic disorders like diabetes, hypertension, asthma. We don't think of it that way because there's so much stigma, but in general, people do as well, like with medication adherence, appointment adherence, behavioral, exercise, those kind of things. In general, people do as well as these other chronic conditions. A lot of what makes addiction different is that we, for many 100 years or more now in the US, we've kind of had a very all or nothing way of looking at addiction treatment. So you're either abstinent from all psychoactive substances or you're still using. And that's not really the way, again, that we look at other chronic disorders. With those, we much more often look at kind of along a continuum of how somebody's doing with the behavior, but also really focused on their consequences. And again, similar to like I said, with DSM and with the definition of recovery, it doesn't necessarily, always correlate with use alone. So again, you want to look at use, but you really are also looking much more at the consequences and how someone's functioning. And again, that's just not how we've tended to look at addiction until recently here in the US. The other thing is that we tend to look at episodes of treatment, whereas again, this is a chronic disorder. So we talk about people going to treatment, like going to residential treatment, as though that is the treatment. And the same with other chronic disorders. If you have like a flare up of your diabetes or your blood pressure, then you need to be hospitalized. When you get out, you continue in treatment. But again, we've typically looked at addiction just in a different way. And again, if you look at it the same as other chronic conditions, it's much more similar. So when we're talking about treating addiction, we're looking at obviously the outcomes for the individual. And, being totally abstinent from all substances might be one of the goals, but even just reducing use or reducing the consequences of use is really a significant goal. But there's a lot of other benefits. Probably, we see this with other conditions as well, but given the amount of violence, the amount of crime, the amount of other related things like infections that go along with substance use disorders, treatment of those really also impacts a lot of other things than just the individual's health. So we'll spend a little bit of time on this because people that are not in the addictions field wouldn't really be familiar with this. So we talked about when we make diagnoses of substance use disorders in the US, we tend to use the American Psychiatric Association, the DSM. When we talk about treatment, we use the ASAM as the American Society of Addiction Medicine. And it's not universal, but the majority of states in the US use this. So there's this, it's been updated every few years, but there's this kind of system of like 1 through 4, and then within 1, which is general kind of outpatient, you have different levels that have more to do with the intensity, but also like the top one, the 0.7, has to do with medical, being able to medically manage. So that it depends on the state and the insurance company, whatever, but It has to do with the amount of nursing, the amount of physician time, how soon after someone starts in the program they see a provider, um, those kind of things. So you have that with outpatient. Level 2 is intensive outpatient, or if it's even more hours a week, partial hospitalization. Level 3 is residential, and that goes from 3.1 is which is what people think of as kind of like a recovery house where somebody stays in a place and they also have counseling groups there, but they also are allowed to leave. They can get jobs usually. 3.5 is more intensive, and then 3.7 is the what people think of as, a residential drug program or rehab, um, like Betty Ford, or here in Baltimore, we have the Turk House, Ashley, those kind of programs. Those are these 3.7 where the person stays there, has, groups counseling. Typically there, they're not going out and doing things like working and things like that. Those are these lower levels. And then level 4 is when you're getting addiction specific treatment within a general hospital setting. So, um, like here in Baltimore, Bayview, Mercy, and Midtown all have addiction, or like, people call them detox units or substance use disorder treatment in a general hospital. So those are that level 4 there. So you see there's a lot of these different levels. Um, Again, insurances, sometimes you really have to fight to justify why you want somebody at a different level. When we talk about kind of managing withdrawal, what we used to call detox, you can do that in any of these levels, but kind of how you can do it and different medications you can use, regulations around that will vary depending on which level, and actually they can vary by state as well. Being on maintenance medications like methadone, buprenorphine for opioid use disorder, again, they can be done at any level, but there are different regulations that apply in different levels. Oops. So here, this goes along with ASAM. There are these 6 dimensions that you're supposed to use in order to decide which level somebody should be in. And again, we won't spend time on all these, but they have to do with kind of the risk of serious consequences from withdrawal or intoxication from the actual substance, other biomedical conditions, which, in this case, pregnancy may complicate someone that makes them need a higher level, other psychiatric problems, other substance issues, the recovery environment that otherwise somebody, has to live in, and then really just focusing on other kind of person-centered, really just what the person wants or is willing to do. That's really important. So there are different ways to kind of think of those levels. So some people think that everyone really should start at kind of top down. So everyone should start at the Betty Ford residential 3.7 program. And then as you finish that, you progress down um, until you're, just going to outpatient. The kind of inverse of that is bottom up. So that's where you start at the lowest level. And if you're doing well there, then you stay there. If you're struggling there, then you kind of progress up the levels. And insurance is, sometimes you really have to fight. They aren't going to approve somebody to go to a residential program if they've never tried outpatient before. And so again, there are different studies. It's obviously very hard to do controlled studies of different types of treatment and have good follow-up. So a lot of this isn't based necessarily on the best studies, but what most studies have shown is that what's best to do is try and match the person. So individualized treatment and not make everyone start at the highest level and progress down, or vice versa. It's really trying to figure out, again, using these, where the person needs to be and match them to the level that they need. Also, as we talk about treatment, a little bit about self-help or mutual help groups, AA, NA, things like that. Most people do not consider these formal treatment, though some people do. When there's a group for pretty much everything out there. And there are groups for not only the affected individual, but the family, like Nar-Anon, Al-Anon. Those are for significant others of the person with the problem. Just want to mention a little bit as we talk about drugs and specifically opioids later on, that NA, Narcotics Anonymous, is there, and it's an important thing that people can use. There is an issue with Narcotics Anonymous that, as I mentioned before, around medications. So Narcotics Anonymous says that if you have a history of using opioids and you're on methadone or buprenorphine, you can come to our groups, but they say that you're not in recovery, that how people count their time that they're abstinent from drugs. If you're taking methadone or buprenorphine, NA doesn't consider you to be abstinent. So they don't let those people say that I have 90 days or whatever. So it can be hard for some patients who want to use that, the support of NA, but feel that they really can't be open about being on a medication that is really helping them. So I think it's unfortunate that NA kind of has this double standard. There's some people that don't like the kind of 12-step philosophy, and so there are a bunch of non-12-step mutual help groups out there. A lot of people have heard of Smart Recovery. That's kind of based on kind of cognitive behavioral therapy, and actually has a leader, a formal kind of trained leader. But there are a lot of other groups out there, and with the internet, and especially since COVID, a lot of groups have popped up that there are a lot of people that find really helpful these online support groups, just to be aware of for your patients. So as we're talking about treatment, it's also important to remember that pretty much with all substance use disorders, there's an increase in other psychiatric conditions, and again, the inverse, that pretty much anyone with a psychiatric problem, there's a higher chance of a substance use disorder. This is from the National Survey on Drug Use and Health. If people aren't familiar, that's the annual survey that gets done every year to look at substance use and psychiatric issues. And this is just showing, the blue is people with mental illness, the red is people with substance use disorders, and the purple is the overlap. So there's a large overlap, and when you're again talking about pregnancy, even higher rates. So really important to remember that as you're trying to help somebody get treatment for their substance use disorder, because in general, even if one clearly kind of preceded the other, that somebody started drinking, say, because of their depression, once somebody has been living with their substance use disorder and their psychiatric illness for a while, they become so entangled that just treating the one isn't going to stop the other one. So it's really important that people are getting treatment for both. There are kind of different models of that. A lot of that has to do with the way addiction treatment has been viewed in the US, and the way the funding has been. Traditionally, the funding for substance use disorders and the funding for psychiatric disorders has been very separate. Luckily, we're trying to integrate that, but still the system is not really well suited to help people with both disorders. Many people end up in these kind of parallel systems where they're going to one clinic for their substance use disorder, one clinic for their mental health. sometimes you'll hear about this serial model. The VA used to do this, say, with PTSD, that in order to get into the PTSD program, you had to stop using substances. So you had to go to the substance use disorder program first. Once you did well with that, you could get into the PTSD program. But if a lot of your substance use has to do with your flashbacks or your hypervigilance or whatever it is from your PTSD, it's really hard to stop using to get into the PTSD treatment. So in general, the best treatment, which seems obvious, but it's not typically what happens, is an integrated model where somebody's getting everything together. And then if in this case, put in the pregnancy, then a program where you're getting, again, all of that together. But it's hard enough just doing this and that in the pregnancy. There's just not a lot of programs that do a good job of being able to, provide all of those in one program. Let's go skip over this. The other thing is with substance use disorders, there's a lot of trauma, depending on where you're working, very, very high levels of trauma. So again, it goes along with the psychiatric disorders, but making sure that a program's also, doing good trauma-informed treatment. That's become, much more something that people talk about and really try and focus on when they're treating addiction and psychiatric disorders. So again, it's another component that just helps to make treatment better. So as you're trying to figure out what's good treatment, and it's very hard because there's so many programs now. Just in the last 5 or so years, as Medicaid has started paying more for different levels of treatment, there are more halfway houses, recovery houses, outpatient programs, more places doing methadone and buprenorphine. We have over close to 110 methadone clinics now in Maryland, 30 some just in Baltimore City. So it's again, that's just really, really grown over the last 5 to 10 years. So it's often really hard to know what's a good program. These are, the things that make a program better. So using evidence-based treatments, being person-centered, trying to individualize treatment, using those recovery, the recovery philosophy I mentioned earlier, having trauma-informed care and being able to deal with other psychiatric disorders. So again, it's kind of easy to come up with that list. And the problem is that knowing when you're trying to refer somebody for treatment, is the program, because a lot of programs will say they do all these things, and some of them will do some of these things somewhat, but it's really hard to often know what really of these things a program is good at. But here I just mentioned again, really important to individualize. So again, so often in the US, we've had this kind of everyone had to do the same thing. Like I said, start with residential treatment and go down. And it really, people do better when you really individualize and this person-centered, taking into account their desires and really what they're able to do. Measuring progress in treatment. Again, we have just been so focused on, in the US, like focusing on the drug testing. And, like when I started doing this, 25, 30 years ago, many of our clinical meetings, this is all that people wanted to talk about was the drug results. And again, that's one piece of information, but you really want to be focusing on all these things here, decreasing use, risky use, the consequences, and increasing those things we mentioned with recovery, how are they doing with all these other aspects of their life. So, again, it's hard in this field, and we tend to focus more on urines, and when we're talking about pregnancy and postpartum, it's one of the only objective things we have. It's hard to measure some of these other things. It's hard to even measure, use without looking at toxicology, but again, just focusing on that really doesn't give you the whole picture of how somebody's doing. So when we talk about evidence-based treatments for substance use disorder, we'll talk a little bit more specifically about opioids and alcohol, but we have 3 medicines for opioids we'll talk more about, 3 for alcohol, tobacco. We have a number of nicotine replacements as well as bupropion and varenicline. There are off-label medicines that are used. I'll talk a little bit about those with alcohol. And then there are a bunch of different types of psychotherapies that have been studied, specifically for substance use disorder, some of them more for certain substances than others. Cognitive behavioral is very big. Acceptance and commitment therapy, ACT, is a very big one. Contingency management, that's where you use positive reinforcement. So the person can earn, say, gift cards or something for, sometimes it's based on their urine drug testing, but sometimes it might be based on other behavior, like attending your OB appointments or whatever it is. So again, there are a lot of different therapies that are also evidence-based for addiction treatment. Down here, I have acupuncture, yoga, relaxation. There are other things that are used and they have some evidence. There are things that are harder to study. It's harder to do placebo acupuncture, but there's some evidence for them, but not as much as for the therapies and the medications. Just to talk a little bit about natural remission. So it's hard to know because we don't see these people, but there are definitely people with substance use disorders that can stop on their own. They don't need formal treatment. Some of them use things like, self-help books, things like AA, NA. So again, we tend, and most of us in this field, we see kind of the people that are struggling the most. But it is important to recognize that there are people with substance use disorders that can deal with them on their own. Some of the other things that help, natural contingencies, and often getting pregnant can introduce that natural contingency that we mentioned, that can help some people with that. We don't have time to really talk about this now, but there's also this whole idea in treatment of substance use disorders of involuntary treatment. We don't do that here in Maryland, but there are other states that have done it just in general for substance use disorders, and some of them really specifically for pregnancy. Again, there's a lot to discuss with that, but just to be aware that it's something that's discussed often and has been tried in different places, whether forcing someone to treatment, whether that's a good thing and whether it actually works. Okay, so the rest of the time, we're just going to briefly talk about treating alcohol use disorder and then opioid use disorder. So I mentioned we have 3 FDA-approved medications for alcohol use disorder. And again, this is in general for everyone, not just for pregnancy. And then under there, I have things that are either experimental or not approved. Some of these, though, people may have heard, but especially the top 3, Dansitron, gabapentin probably the most, and topiramate. These also have positive studies with alcohol. They're just not FDA approved. So they're fairly often used off-label to treat alcohol use disorder as well. Just again, we don't have time to go through all the details of these, but disulfiram or Antabuse, that's the one that affects how our bodies metabolize alcohol, and they stop basically the metabolism where this acetaldehyde builds up in somebody's body, and that can make you have this, feeling flushed, headache, nausea, dizziness. It can, very serious, it can lead to death. But really, it's just uncomfortable. And the idea is that the person, knowing that this is going to happen, if they drink while they're taking the medicine, it helps them not want to drink because they know of this problem. Um, Talking about it in pregnancy, it's very little study, and what, just to say this up front, there's very little study of alcohol in these chronic treatments in pregnancy. Um, a little bit of animal studies where disulfiram showed some reduced brain weight in rats, but again, very little, just some case reports in pregnancy. So it's really just hard to know. And most of these are just not well controlled. In this one, the people took antibiotics, but they had also been drinking during the pregnancy. So again, it's really just hard to know. Naltrexone, the second medication, is the opioid antagonist, opioid blocker. We use it both for alcohol and opioid use disorder. It helps the person, like if they drink, it's a less reinforcing behavior. So it makes it less likely that they'll continue the behavior because it's less reinforcing. Um, Again, not very well studied in pregnancy, especially for for alcohol use disorder. There are some studies I'll mention later about it for opioid use disorder, but very little for alcohol. So again, a little bit of evidence with animals, some case reports in pregnancy. One study, very again a small case report that some of the babies whose moms took naltrexone were born earlier, but again, not a lot out there for that. And then the third medicine for alcohol use disorder is acamprosate, and that works on our glutamate systems. Again, very little in pregnancy. There have been a little bit more studies in Australia, and they're fairly positive as far as looking at it. There was no difference with babies whose moms took acamprosate in these, birth weight, birth defects, things like that. So here there was some spontaneous abortions, but again, there was no comparison group. So it's really, again, very little study, but at least this one here didn't seem to be a problem. So this might be something to think about to use if somebody's really, really struggling. Okay. So lastly, we'll talk about opioid use disorder. And again, we're just really hitting the highlights here. We do other webinars like this just on treating opioid use disorder in pregnancies. So, but really just to highlight that there's so much evidence that these are helpful. Again, not just in pregnancy, but with all people with opioid use disorder. We're trying to get away from the term we used for a long time, MAT, medication assisted treatment, because as we do more and more, we use it more and do more and more research, we find that there are people that do well with these, some people without any other treatment. They don't need counseling. So we're trying to, give credit to the medication that it in and of itself is a treatment. It's not just assisting other treatment. And again, it's the same idea of, you know, somebody may do well with changing their diet and exercising, but the insulin alone may really help them with their diabetes or similarly with something like depression. So we have these three medications for treating opioid use disorder. And I just mentioned that here. Again, we don't have time to go through them, but there are other things that other countries use kind of officially, clinically, but there are other things that are also being looked at down here. So I put these because they're, with our opiate epidemic, that it just tends to be in the news more, and some of these other treatments we're hearing more about in the news. I also just put these aren't ready to be used yet, but there's studies actually looking at brain stimulation for treating opioid use disorder, and there's a vaccine specific for fentanyl that is being studied as well. So just a reminder of why we use these medications for opioid use disorder, because a lot of people say, well, why put somebody on another opioid to treat their opiate disorder. But the idea is here that you're trying to avoid this when somebody uses heroin or fentanyl, they get this real high initial, hit to their brain, which gives them that high. And then as it wears off, they go through a period of feeling kind of normal. And then once they're physically dependent, they go through withdrawal. So that leads to them, starting to use multiple times a day, often just to prevent going into withdrawal. So the idea with methadone and buprenorphine is to keep the person, their opioid receptors occupied, and keep them in this kind of middle area here where they're not feeling high from it and they're not going into withdrawal. Lots of benefits. Again, this is in all people, not just pregnancy, as far as substance use. But again, looking at all those other things I mentioned, criminal activity, the person just getting back, getting with their life, cutting down on HIV, hepatitis, other injection-related infections, significant effects on mortality. These are looking at both methadone and buprenorphine, and if somebody's using opioids, they have a 6 times, the kind of normal general population risk of dying, not just from overdose. This is looking at all causes of death. But if somebody gets on the medications, doesn't go all the way back down to 1, but it goes down below 2. So it really, this being on medication really significantly helps with risk for mortality. In pregnancy, the studies show that there, all these different benefits. A big one is just less risk to the fetus than if mom is using, these really tainted street drugs. Less adverse pregnancy outcomes, birth outcomes, less chance of these other things that mom might get in like while using during pregnant, which could add to the risk of the pregnancy, less risk of these other behaviors. And there is a risk of neonatal abstinence syndrome that we'll talk about, but it's easier to manage when it's predictable from the medications that mom is taking. Just some of the other specific benefits: increased fetal growth, head circumference, reduced mortality, less preterm births, less infections, preeclampsia. So again, lots of benefits of the medications in pregnancy. Looking at long-term outcomes, it's really hard to study and really hard to control for all the confounders like poverty and things like that. But again, in general, the studies show that it doesn't seem to be associated with long-term developmental or cognitive impairments. Just to mention a few of the things specific in pregnancy, when you're looking at buprenorphine and methadone, but especially methadone, often, usually in the 3rd trimester, but sometimes even earlier, because of differences in, the way, just the body distribution, but also in metabolism based on some of the hormonal changes. Methadone especially often needs to be dosed at least twice a day, and the dose often needs to be increased. Though it doesn't, it's not across the board. I've seen plenty of people that it didn't need to be increased, but certainly for many it does, both increased and split. So just to be aware of that. Talking, there have been a lot of studies now, but this is still the largest and the kind of the most influential study that looked at these, methadone and buprenorphine. So there are 130 babies born whose moms had either taken methadone or buprenorphine. And really the bottom line is that everyone did well in the medication. No really significant differences in effects for mom or the newborn. The biggest effects were that the babies whose moms had taken buprenorphine tended to have less severe withdrawal, needed less treatment and were in the hospital significantly less time. And like I said, this was done in the early 2000s. Since then, there have been a number of studies. There was actually another one just yesterday I saw that again looking at buprenorphine. That one also looked at buprenorphine compared to no other treatment, um, but it does seem pretty clear that buprenorphine tends to lead to less opioid withdrawal in the newborn. Another thing to be aware is when it first came out, buprenorphine here in the US, the recommendation was to use the plain buprenorphine. Subutex was the brand name then. Suboxone is the one where buprenorphine is compared to naloxone. And it was recommended mostly because prior to the US making Suboxone, Subutex was the only thing available in the countries where buprenorphine was used prior in the 1990s. And so there were a few studies on pregnancy then with this. So partly on that, partly just to try and expose the fetus to less substances, the recommendation was that you take the plain buprenorphine. Since then, though, there have been probably more than 15 or so now using the combination one, and they all show that there's no more negative outcomes. And there's actually one that showed that the babies whose moms took the combination actually had less withdrawal than the plain buprenorphine. So, but this still comes up. So it's something that, to talk to the pregnant person about kind of what the recommendations are, because the FDA hasn't changed the wording about the recommendation with the plain, but there's really a lot of evidence now. And actually some people prefer the strips. One, they've often are buying them already on the street before they come into treatment, but also the plain tablets can be really chalky and some people just don't like the taste and the consistency of it. So again, it's just to be aware that the recommendation to use the mono product isn't really the same. Just to finish with a little bit on naltrexone, we tend to not recommend it as much in pregnancy because it's harder to get somebody on it because of the risk of putting the person into precipitated withdrawal. But there have been a few studies, and mostly in Australia, but there's actually been one, here in the US and Tennessee, where, the outcomes were actually really good. So, most, like ACOG and other organizations mostly recommend methadone and buprenorphine because they've been studied more in pregnancy. But a lot of times, say the person is in a residential program or they're already off of opioids and it's easier to get them started, it may not be, a bad thing to think about. Again, it just has not been studied as much, but the studies there really do show that it potentially is a good treatment as well. And then the baby doesn't have opioid withdrawal. So just to finish with choosing, and again, it's kind of goes along with all the other things I already mentioned, but it's really important to recognize that there are differences in the medications as far as the medications themselves, but there are also differences as far as the regulations that apply to them. Methadone has more regulations than buprenorphine and naltrexone. Buprenorphine has more regulations than naltrexone. So you can use them differently if somebody's in an acute care hospital versus being in some other setting like even correctional or an outpatient clinic. So it's just important to recognize, like again with methadone, that the person has to go every day in the beginning to the program. That just may not be doable if somebody doesn't really live near a program. Luckily, we've changed just in the last year, the regulations around methadone have loosened in the US. They were already loosened because of COVID since 2000, but then SAMHSA just last year made some permanent changes. So it's, you know, it's still more regulated than the other medications, but it's definitely better. It's easier to get take homes faster now. You can make a lot more exceptions, again, especially if somebody is pregnant, if they live farther away from a program. So, but again, it's just important to remember that when you're talking to the person about, you know, the different medications, you have to take into consideration the practical issues about the regulations as well. Just a reminder that Maryland Medicaid has this mom program. There are lots of resources out there for pregnant people. You know, who knows what the future of Medicaid is, what, you know, what may get cut and how that's going to affect this, but we have to hope for the best. And just to finish up, I think Tracy already talked about this some, but if just remembering the MACS, the Maryland Addiction Consultation Service. If you're interested and you're not aware, we have a monthly, it's called an ECHO. It's kind of a virtual support group for providers that are working in the perinatal space with people with substance use disorders. We have a phone line Monday through Friday that you can call in with kind of general questions, but you can actually call with specific clinical questions and lots of other things. Again, I think Tracy already talked somewhat about it. So I know we're already past time. I can answer a couple questions now, or, you know, if you have other questions, you can send them and we can get your answers virtually. So.
Thank you so much, Dr. Welsh, for a really great presentation. Yeah, please feel free to put questions in the chat. And as you said, we can take a couple questions. I do see one that just came in. How do you handle entitled and irresponsible attitudes when making your recommendations? How do you avoid fostering dependencies on methadone and meds for opioid withdrawal?
Say that again, Tracy.
Sure. How do you handle entitled and sorry, I just went away for just a second. How do you handle entitled and irresponsible attitudes when making your recommendations? And how do you avoid fostering dependencies on methadone and meds for opioid withdrawal?
Okay. So I'm not really sure what you do. If you mean attitudes from other providers or from the patient or from, a lot of times it's the patient's family that feel strongly about whether somebody should be on a medication or not. So you're going to see, unfortunately, attitudes from all of them. Also, yeah, I'm guessing there may be some CPS workers on here, but I've definitely seen it from some workers as well. So, yeah, you really just have to try and educate people about what the studies show, and then really just try and figure out where they're coming from, what it is that they have these attitudes. Like sometimes they have a person, you know, they had a family member that had a bad experience with a medication or whatever. So, you know, I think you have to accept that there are people that definitely have feelings about these things. And again, we've had a lot of stigma, and certainly it's still there. I think things are better now than they have been before, but addiction and especially opioid use disorder and the medications have had a lot of stigma here. So, so it's not surprising that there are people are going to have feelings about it. So, so again, I think just trying to help educate them, but also to understand kind of specifically for them where they're coming from, why they have these feelings.
Thank you, Dr. Welsh. And again, I think we might have time for another question or two. I will say in the meantime, again, we are going to be putting information in the chat for the login to go back to your page for the portal for Oasis. So you can do that eval link and you can log in. And after you do that, you will be able to access your CME and your CEU certificate. Again, it's all through that portal. We do have another question that just came in. Time for one more question. Thank you, Marciel, for putting that portal in the chat. You can click on that. And then the other question that came in is, how do you approach ambivalence?
Yeah, again, that's a whole nother talk. So, but again, it's all like, people have heard of motivational interviewing. So it's really trying to figure out, because I mentioned before, really changing any behavior is going to have ambivalence, because there generally were positives associated with behaviors at some point in the person's history with the behavior. So it's again trying to find out for them specifically what, where that ambivalence is coming from, and then trying to kind of work with them on the positives of changing the behavior versus kind of how do you address, the ambivalence, some of the least positives that they may have had in the past from the behavior. But again, that's a lot. We do have one of these. I think they're recorded, a whole one-on-one motivational interviewing in pregnancy around behaviors. So, but again, it's not a one size fits all. It's really trying to figure out specifically for that person, where the ambivalence comes from, where, the significance of the behavior for them.
And Dr. Welsh, if you have time for just one more question, another question just came in. How do you avoid fostering dependencies on, quote, MATs and BUPs, et cetera? So medication-based treatment or buprenorphine.
So I'm not really sure what avoiding fostering dependency, but the same way, as we talked before about, if someone has another chronic disorder and the medication that they need to take helps them with that disorder, I guess, I don't know if you mean a psychological dependency, but if someone needs to take a medication to help them with any chronic disorder, I don't know that we want to avoid fostering helping them accept that medication is something that they should take to help their disorder. So there's some people that, again, same with hypertension, they may change enough other behaviors and that they can come off a medication. And the same is true with substance use disorders, but especially with opioid use disorder, the relapse rates are very high. And given that a single use with an opioid can be fatal, relapse isn't the same as relapsing on, say, marijuana or smoking cigarettes. So, one relapse with opioids can be fatal. So, so I don't, I think that it's helping the person kind of figure out where they are, but I don't know that there are people that need to stay on the medications chronically. So I don't know that you're trying to not foster them being dependent on the medication.
Thank you again so much, Dr. Welsh. I know that we're out of time and went over a bit. So again, thank you everyone for joining and taking time out of your afternoon for today's training. Again, if you do have any other questions, as Dr. Welsh mentioned, you can always contact us at Max for Moms. Our consultation warm line is available. You can call us anytime for a curbside consultation for clinical questions, as you mentioned, on Monday through Friday from 9 to 5. And again, you can log into your portal and the link is in the chat to access that survey to complete the eval, and then you'll be able to download your CME and CEU certificates. if you have any other questions, don't hesitate to contact us. Otherwise, and we can end for today. And again, thank you so much, Dr. Welsh, for presenting.
Great, thanks, everybody.
Take care, everyone. Have a good afternoon.